next presenter is Dr. Sidney Zisook, who's going to be speaking to us about complicated grief and bereavement after suicide and other causes of death. I asked him how to pronounce his name correctly, and he said Sidney. Sidney Zisook is a University of California, San Diego Distinguished Professor of Psychiatry. He completed medical school at the Stitch Loyola School of Medicine and residency at Massachusetts General Hospital and clinical fellowship in psychiatry at Harvard. That's pretty good. As co-founder of the San Diego chapter of American Foundation for Suicide Prevention in 2007, he launched and co-led a healthcare team suicide prevention program, the Healer Education Assessment Referral, HEAR program for UC San Diego Medical School and Health Science Community. He currently directs the UCSD Physician Support Peer Program. Dr. Zisook's key academic interests include suicide prevention with a special focus on healthcare workforce suicide, grief and prolonged grief disorder, treatment-resistant depression, and medical education. He has published over 400 scientific articles, chapters, and books in these areas. So please welcome Dr. Sidney Zisook.
Thank you. Can you hear me okay? Good. I feel I'm honored to have been invited here and really happy that I ended up coming early to listen to those terrific talks and very tough act to follow. But the last couple of talks is going to allow me to cut through some of my slides fairly quickly because it was covered so beautifully. And I'll try not to repeat it. Disclosures. I get research support from a company called Compass, doing a really fun study with them on psilocybin for treatment-resistant depression. That's been neat. No other disclosures that are relevant. Just to shout out to my many collaborators in the area of bereavement and prolonged grief disorder. And in the interest of time, I won't go through identifying all of them. But whatever I'm talking about today is really part of a team approach. It's nothing I could have done on my own. My objectives today are just to describe some similarities and differences between grief after suicide loss compared to other instances of grief and bereavement, to describe briefly the key characteristics of prolonged grief disorder, and then to talk about some evidence-based treatments for suicide bereavement in the context of prolonged grief disorder. So first, just a brief overview of grief, the response to loss, to any loss. I've just had, my introduction was a little inaccurate. I'm no longer a distinguished professor. I'm distinguished professor emeritus. A loss. We learned about retirement being a stress factor earlier. So grief is the response to any loss. Bereavement is a special kind of loss. It's loss when somebody we love dies. And so I'll be using those kind of interchangeably, but when I talk about grief, I'm really talking about bereavement here. This is probably my most important slide about grief by my favorite author, Anonymous. Grief never ends, but it changes. It's a passage, not a place to stay. Grief is not a sign of weakness, nor a lack of faith. It's the price of love. Okay? That's what grief is. There's no formula for how to grieve. Every one of us grieves differently. We grieve differently in different contexts. Depending on the loss, we grieve differently over time. But there are some important commonalities. Whoops. Although highly variable, there's generally at least an initial sense of disbelief. Oh no, this couldn't have happened. Is it really true? That's a kind of a uniform reaction to the loss of a loved one. followed by very strong emotions, often, both negative and positive. Not invariably strong emotions. I must say, God, when my father, when my mother died, it wasn't overwhelmingly serious. It was timely. They were in their 90s. It surprised me, relatively mild grief, not abnormal. On the other hand, when my sister died, it was a very intense and serious and difficult grief, and it was very untimely. So it varies in each of us. But often they're feelings of insecurity, emptiness, confusion, physical symptoms, heartache, the broken heart, sighing respirations, abdominal pains, headaches, a variety of physical symptoms that are often part of the grief response. Intrusive thoughts that can come out of the blue, especially early on. Over time, the thoughts about the person who died become kind of more tied to reminders of the person or situations or anniversaries, etc. Feelings, thoughts, behaviors, at least initially, are very much focused on the person who's died, and along with that, kind of a loss, at least temporarily, of ongoing life, which is why we have periods of time respite for grief, time off of work, et cetera, with the knowledge that you need to take some time away from other duties in order to allow yourself to grieve and to focus on your loss. Okay. And this is just and I'm not going to go through this in detail because not a talk on grief, it's a talk on suicide and grief. But this is a smattering of the many feelings, behaviors, and thoughts that are attendant in a grief response. There are a whole host of them. Just a summary, and this comes from a study we did years ago of widows and widowers who were bereaved, and we followed them over a 2-year period of time. Why 2 years? We chose 2 years because we thought by the end of 2 years, grief would be pretty much over. And that would be an adequate time to study grief. Like all of our other hypotheses, we were dead wrong. 2 years is not the time when grief is over. In fact, it never ends. And we wish it had been a lifelong study instead of a 2-year study. One of the things we learned, one of the things in going into the study, we thought we'd replicate some of Kubler-Ross's stages of death and dying and grief, and we were unable to do that. There were no circumscribed stages. You don't go from shock and denial to anger and depression, and those stages, they're phases that come and go over time. And at any given time, 1 or 2 of those may be more active than at other times. We did learn that the characteristic of the pain of grief is that it comes in bursts and waves, kind of like a panic attack. A burst or wave may last 10, 15, 20 minutes, and then a respite and time away. Those bursts and waves are pretty frequent and intense early on for many people, and over time they lessen in both intensity and frequency and become more tied to reminders or thoughts or behaviors related to the person who died. Whereas at first they're more autonomous, they're just there. Positive feelings are intermixed. So the feeling of relief, especially if someone died from a long chronic illness, pride, happiness. Many of you have how many of you have given eulogies? Several. And probably for most of us, that's as funny as we ever are when we give a eulogy. Positive feelings are intermixed. Happiness and joy are possible. And that's one of the natures of grief. One of the ways we differentiate grief from depression is those positive feelings that are so much a part of grief that are not so much a part of a serious depression. The intensity peaks in days, weeks to months. One of the frequent questions we're asked is, how long does grief last? Well, unfortunately, it lasts forever. Every time I give this talk, I think about my parents. I think about my sister. I'm still grieving them, even though they're not interfering with my day-to-day life, and I'm not crying about them very frequently. But generally, the intensity begins to peak within weeks to months, and if not that, within years. But it doesn't totally go away. So on the right, grief and loss are complex, multifaceted, multi-layered. Loss and our experiences of grief are integrated into our lives, not things we get rid of. So acute grief, which can often be very painful, over time evolves, doesn't go away, it evolves into what we call integrated grief. The sense of disbelief lessens, the intense emotionality subsides, thoughts and behaviors recede into the background. The deceased begins to rest peacefully within our hearts. Well-being is restored along with a renewed sense of purpose, meaning, connection to others. So integrated grief. In integrated grief, the person who dies rests peacefully in our hearts, along with a renewed sense of purpose, meaning, and connection to others. Okay. So in summary, just the summary of grief. Bereavement is the loss of someone meaningful to us who dies. An acute grief response, we don't have to choose to have it. It's there, it's automatic. It varies in intensity and evolves over time into integrated grief. The acute grief is often very painful. Adaptation to it proceeds naturally in most bereaved people. There's not much they can do to make it happen. It happens. And they generally don't need any kind of professional attention or support, although support of loved ones and friends can be very important in helping one transition into integrated grief. Management principles, and I'm not going to belabor this, but some of the same management principles we just heard in the last hour of empathic listening. I'm sorry for your loss. It sounds like kind of lame that we all say that, and that's fine because we are. But if you're a therapist dealing with somebody who's bereaved, I'm sorry for your loss as a starting point, but please tell me more. And more about the person, more about the relationship, more about the circumstances around the loss and the grief itself. Providing psychoeducation. One of the things it's in my toolkit. I say this all the time. Grief is the form love takes when someone you love dies. So there's nothing abnormal or pathological about it. It's the price of love. It's what love is when somebody has passed away. Okay. And I'm not going to go through the rest of this because, again, this is not a talk on managing grief, and I want to make sure we save time for suicide bereavement. Okay. Suicide loss tends to be more complicated than other forms of bereavement from other causes of death. And that's now look at some of the similarities and differences. Fortunately, I can skip over the facts about suicide because they were covered so comprehensively and eloquently last time. Let me just say it's common. And I know there's some physicians in the audience, so just one piece that wasn't covered last time that is so sobering for us physicians. The single largest cause of death amongst trainees, amongst residents and fellows, is suicide. So sobering statistics. And physicians and other healthcare workers are certainly not immune to suicide. Although we have the resources, we have the knowledge, our rates of suicide are right up there with other people. In fact, female physicians have higher rates of suicide than other females in the general population. Male and female nurses have higher rates of suicide than other men and women. So it's there. And the unfortunate thing is, as though we in the healthcare professions are so smart and clever and well-resourced, and most of us have really good insurance, we're no more likely to get treatment when we're depressed or at risk for suicide than anyone else. And in fact, some studies suggest we may even be a little less likely. Okay. So that's the facts and figures. That was already covered. Let me go through this one. Just one more quote, and this I picked up from the AFSP website. One learns to live with the loss, the tragedy, the waste, the gaping hole in the fabric of one's life. There is no closure, nor would I want one. I want to remember him all my life, vividly, his laughter, the smell of his sneakers under my bed, his moments of joy, his humility, and his integrity. And this is a pretty common type. The idea is if you really love somebody who's died by suicide or any cause of death, you really don't want to forget them. You don't want to stop grieving. That's a living, loving memory. Again, it's the form love takes when someone you love dies. Some ways that suicide bereavement may be different or similar to other bereavement. If we look painful, bereavement is variable. As I mentioned, for me, it was much more intense when my sister died than when either of my parents did, much as I loved them and they loved me. With suicide, it's more invariable. It's almost always very painful. Prolonged. In bereavement, over time, grief gets integrated. It's lifelong, but it gets integrated into our daily lives and isn't so painful. After suicide, that transition to integrated grief tends to be much more prolonged. The acute grief may often be more intense, but that transition is delayed. And it can be delayed for months to years. It's just very variable. Depression. Depression is often triggered by psychosocial events, negative things that happen in life, like bereavement. So bereavement can trigger a depression in a vulnerable person. It's probably not much more likely to be triggered after suicide loss. The data, surprisingly, is that after suicide loss, depression is not necessarily more common than after other types of losses, unless the person has a certain vulnerability already. And they may be more likely to have that vulnerability, as I'll show a little bit later in a study we did. Lifelong depression is more common in someone who's a suicide loss survivor than people who are bereaved for other causes of death, for lots of reasons. It may be because of their genetic relationship. It may be because of lived experiences that are overlapping, and maybe the stress of living someone who's chronically depressed. So depression is common even before the death, but no more likely to be triggered by the death itself than other causes of bereavement. Similarly with PTSD, the rates of PTSD after suicide loss are, in some studies, about the same as the rates after other losses, especially other sudden and unanticipated losses, like after an accident or homicide. And in some studies, they may be a little bit more prevalent, but not a huge difference like you'd guess. On the other hand, prolonged grief disorder, and I'll define that a little bit later, is much more prevalent after suicide loss than other types of losses, even than after accident or homicide. And suicidality, feelings that life isn't worth living, or even more active suicidal thoughts and behaviors, are more common after suicide loss than after other losses. Okay. And we heard a little bit about that in the last hour, and I'll talk a little bit more about that later. So in suicide loss bereavement, all the burdens of ordinary grief are still there, but there's some unique challenges, some themes that may be more intense or different. For example, the question why. It's never ending, it's never answered. But the first thing that people ask about when someone has died by suicide, why? How could that happen? He seemed like he was getting better, or things were turning around. And that unendless why question is much more prevalent after suicide loss than other types of loss. It can be unending, trying to make sense of the loss. The sense of responsibility, guilt, shame is more common after suicide loss than other kinds. What could I have done differently? What should I have known? Was it because of my behavior that the person took their lives? Blame the person who died. How could they do that? Blame myself because I didn't do enough to prevent it. I didn't know enough. Blame others. Oh, if his wife had only been nicer to him, it would have never happened. Or blaming God. How could a good God let something like this happen? Shame, social isolation, hiding the cause of death, they're all much more prevalent after loss by suicide. Family relationship disturbances, divorce is so frequent after a child dies by suicide because it's such a stress on the family. And again, anger, a sense of rejection and abandonment. how could the person do this to me? How could they leave me? And, you know, what can I do now? Okay. So those are some of the differences, those themes. I'm going to skip most of this, but again, I mentioned earlier, suicidality in the survivor is more prevalent, and prolonged grief disorder is more prevalent. And I'm going to skip this next series of slides because it was really so beautifully covered in the last hour, and I can save some time. The one thing I will say for those of us who are clinicians, in addition to the kind of support and encouragement and the care model that we heard about, don't forget also treatment of co-occurring conditions, you know, like depression, substance use, PTSD, and prolonged grief disorder. All are conditions that are seen not infrequently after suicide loss and can be forgotten in the context of someone who's bereaved. And it is important to also recognize and treat those conditions. Okay. Support groups can be very, very helpful. What do support groups do? Well, they help with everything from dealing with the practicalities of life, coping with the ripping emotional wounds of suicide, provide connections, provide advice, provide some sense of someone who's been there, done that. There's purpose in being part of a group and helping others get through it. So a whole host of things about support groups that can be very helpful. We actually did a study of in San Diego when we started the AFSP branch. We did a study, a survey of individuals in San Diego who have lost someone to suicide, and we asked them what was most helpful to you in the healing process, and what was the least helpful. And most helpful was talking to other survivors, sharing, family and friends who listened, etc. But interestingly, if we look here at what was most helpful, support groups, what was least helpful, support groups. Not for everybody. And we found that the support groups that were most helpful tended to be fairly homogeneous. So a support group of people who have lost children or who have lost parents, who have lost it, is more helpful than a very heterogeneous ones with all sorts of losses. And certainly a support group of suicide survivors, as opposed to a mixed group with other losses, can be more helpful. But they're not for everybody. And for some people, they can be very helpful. The other thing that was on both sides of the equation are family and friends. On the one hand, family and friends who listened and didn't judge, very helpful. Family and friends who wouldn't talk about the person or the death, not so helpful. Okay. Pardon? I'm trying to get back there. Okay. Yeah. Yes. And I'm actually going to say a little bit, and annual walks as well. I think there's a walk coming up in Los Angeles soon. Yeah. So high on the list of people who for supports were attendance at the at annual walks, and I'll say a little bit more about ISSS Day in a bit. Okay. And here's where I'm going to say more about it. So these are one of my favorite websites for helping people with suicide loss or dealing with suicide is the American Foundation for Suicide Prevention. And they have several different supports that are high in anyone's list of what's helpful. One is they now can help with healing conversations with support. It's an AFSP support program where they'll match somebody up with an individual who has had a loss for a video chat or a phone chat, or if it's in the same city, a live chat. So it's an opportunity to speak openly and ask questions of someone who's been there, someone who's done that. So that's one thing they offer. The International Survivors of Suicide Loss Day, ISS. Have any of you attended one of those? Couple. They're really powerful, aren't they? So the Thursday before Thanksgiving every year, the AFSP sponsors a program, the International Survivors Support, which occurs in almost every big city and now is intercultural, so it's done in a lot of other countries as well, where individuals get together, they share stories, they often watch a very powerful video dealing with suicide and suicide loss and coping with suicide loss. And can be a very, very powerful event. I highly recommend that to any of the patients I see or friends I see who have lost someone to suicide. And they're always thankful for having that recommendation. The AFSP website has support group listings so that in whatever city you're in, it will help find support groups for people who are dealing with suicide loss. The Out of Darkness walks, which occur, at least once a year in almost every city, and in general in September, the Suicide Awareness Month, sometimes in October, can be very, very powerful. And the website has a number of postvention toolkits, toolkits for medical schools, colleges, physician groups who have lost someone to suicide, of how to deal with it in an organizational way and what to do. So lots of resources which can be very helpful. Postvention, we heard a little bit about last hour, is prevention, because individuals who have lost someone to suicide are themselves at high risk for suicide. Postvention is providing support, therapy, treatment when necessary for somebody who is feeling very disconnected, to help them reconnect and to help minimize the risk of suicide for them. And one of the ways of providing postvention is the treatment of prolonged grief disorder. So I want to turn to prolonged grief disorder to just define that for a few minutes and then talk about suicide in that context. So what is prolonged grief disorder? Well, I mentioned that suicide naturally evolves, transitions into integrated grief. Lifelong, not so painful, and it's a way of maintaining our connection with the person who's died, but continuing to live with possibilities of joy and satisfaction even without that person. Sometimes that transition doesn't occur. It gets blocked. Some maladaptive thoughts, the shoulda, woulda, coulda, ifs, the endless whys, the blame, the shame, can all get in the way. And if they do get in the way, instead of grief evolving, acute grief evolving into integrated grief, the grief can get kind of derailed, and that doesn't happen. Instead, the person gets stuck in what would normally be an acute grief response, now being chronic. It's impairing. It interferes with life. It interferes with the ability to reconnect with life, experience joy again. And it was called for many years complicated grief. It's now got a new name, prolonged grief disorder. And prolonged grief disorder has found a place and a label in both the ICD-11, the International Classification of Disease, as well as the DSM. So it's now a clinical condition, and it's defined by persistent, pervasive longing or preoccupation, which causes significant impairment in important areas of functioning. That's the sine qua non of prolonged grief disorder. In addition, there has to be other indicators of intense emotional pain, such as sadness, guilt, anger, denial, blame, difficulty accepting the death, feeling one has lost a part of oneself, or emotional numbness. Okay? So prolonged preoccupation that causes significant impairment and other symptoms and signs of ongoing acute grief. In the ICD-11, the duration, it has to be at least 6 months after the person who's died. The DSM says it has to be at least a year. The reason that 6 months was given is there was some data that suggests if you're still having this really intense disruptive grief response at 6 months, it tends to be chronic. Doesn't tend to go away on its own. DSM was more conservative and said, we'll give you a year. But after a year, if this is outside of your kind of religious and cultural and spiritual norms and it's interfering with your life, we'll call it prolonged grief disorder. And there are treatments for it. So the best studied treatment is something called prolonged grief disorder therapy, or PGDT, which used to be called complicated grief therapy. 10 minutes, ooh, boy. Okay, all right. So I'm not going to let her talk to us now. We've already talked about connection and disconnection. So what is prolonged grief disorder therapy? It's a 16-session, fairly short-term therapy, which is focused on grief, loss, and bereavement. It uses strategies borrowed from cognitive behavioral therapy, interpersonal psychotherapy, motivational interviewing, and others. And the goal is to just doesn't stop people from grieving. The idea is to help get grief back on track, to help them grieve, to stop avoiding their grief, to face the pain. And again, in the interest of time, I'm going to, let me do this one. Just said that there are three real components. One is accept the reality of the loss, and that is really feel the pain. There's something called an emotional revisiting experience that one does over and over again in this therapy, which is really having the person close their eyes and talk about how they discovered the person died by suicide. What was it like? What were you feeling? What were you doing? And it is a very powerful form of therapy. And it's done repeatedly, and it's taped so the person can view it at home and over time. Establishing continuing bonds with the person who's died instead of thinking you have to accept the fact that they're out of your life. It's how do you keep them in your life in a meaningful way? And do this by having them bringing in pictures and images and videos. At one point, there's even an imaginal conversation with the person who's died. And a vital part of the therapy is helping them re-envision a future with meaning and purpose and connection with others again. And there's a whole bunch of exercises related to that. The data on it is, there's been 3 large studies of prolonged grief disorder therapy versus, in 2 cases, versus another form of psychotherapy, interpersonal psychotherapy, in the 3rd study versus antidepressant medication. And in all 3 of those controlled large studies, this form of therapy was very effective, okay? More effective than most therapies or medications for depression or PTSD or anxiety disorders. So it's a very impressive database. In the last of those 3 studies, it was a 4-site study, so there were lots of participants, enough that we were also able to look at those who had been bereaved by suicide compared to other kinds of losses. And we asked the question, how is their grief different? And do they respond to this therapy as well as folks who have been bereaved by other losses? So some of the differences. The group of suicide bereaved, and this is compared to 2 other groups. One group of those who died by accident or homicide, so other acute, unanticipated, traumatic forms of loss. And also the other group, the largest group, is those who had died from natural causes. The suicide bereaved group tended to be younger. They more often lost children than the other groups, and that stands to reason. Before the suicide, they already had more depression, more PTSD, and more suicidal ideation. So when those occurred after the suicide, it wasn't triggered by the suicideness. It may have been worsened, but it wasn't triggered. They already were suffering compared to those who were bereaved by other losses. In our study, after the suicide, there was more PTSD and more suicidal ideation. In addition, they were more socially isolated. They experienced a lot more stigma, more self-blame, more inability to care about others. than those who are bereaved by other causes. So a lot of other aspects of the grief that were different and more severe. Did the therapy help? Well, high completion rates. Over 80% of people completed the 16 sessions of therapy, even in the group who had been suicide bereaved. And the responses were almost as good. They're as good on most measures. A couple of measures, they were better, but not statistically significantly so. But basically the people who suffered a suicide loss did very well with this form of therapy. There were improvements in the grief intensity, in depressive symptoms, and in function. There were also improvements in their kind of maladaptive thoughts and avoidance behaviors. Okay. So we found that this form of therapy was feasible and effective, and also dramatically diminished thoughts of killing oneself. So I mentioned earlier that the suicide bereaved had more suicidal ideation even before the suicide and even before they entered the study. 43% had active thoughts of suicide before the study, 0% after the therapy. So this form of therapy can be profoundly effective and an effective form of postvention by decreasing suicidality in a group at high risk for suicidality. Okay. So I'm going to skip this and going to quickly, just kind of the takeaways is the death of a loved one can be an extraordinarily painful and challenging experience, especially so after suicide loss. Suicide survivors feel alone, they feel disconnected. We heard about that this morning. Supporting survivors involves patience, openness, presence, acceptance, pragmatic interventions, like offering to bring some meals, walk the dog, help with obituaries, etc. Overcoming stigma and addressing some of these maladaptive thoughts and behaviors. But with time and support and targeted treatment, when indicated for those who are suffering prolonged grief disorder, meaningful changes can occur and adaptation can occur. This is a slide of some websites and books and things that are popular. There are a lot of people, I often recommend reading. One of my favorites is A Grief Observed by C.S. Lewis. We all have different favorites. There's a whole lot of them. The AFSP website has a host of books and resources that are available. There are a lot of websites, and these slides are available to anyone. I'm going to summarize my next slides because I know we're getting loose on time. I wanted to talk a little bit about, there are many clinicians in the audience, the clinician as survivor. Anyone who treats a lot of psychiatric patients, especially those with chronic severe disease, probably have had patients who have died by suicide or patients who will. Yes? Yeah. Thank you for sharing that. I wish we had another hour because that would open up, segue into allowing many others of us to share stories like that. We're human. We grieve. when we lose patients to suicide, we grieve. And the first time I lost a patient was when I was a resident, chief resident, and I was given a patient by one of my mentors, and I felt so honored that he gave me a difficult patient to take care of. And that patient had just delivered a baby at a postpartum depression. I did a thorough evaluation. I never saw her again because she suicided. I didn't ever tell the person who referred her to me. I didn't tell my supervisors. I didn't tell my wife. I lived with that in secrecy for many, many years, which I think is par for the course. And I think the bottom line of the slides I'm not showing now are we're human. We need to give ourselves permission to grieve. We need to have self-compassion. We need to talk about it. Just like we know that when someone else loses someone to suicide, they need to talk about it. We need to listen. And so for those of us who are clinicians, let's take care of ourselves and be open to the fact that we are human, allow ourselves to grieve, allow ourselves to take some time off if we need it, because we want to give ourselves as much care as we give other people we love and our patients and our clients in order to better serve the people we love and our patients and our clients. And is there time for Q&A?
Yes.
Good.
Yes, definitely.
Well, that's why we're getting you off the short, so we can move people along our team. Dr. Feldman has a question.
Dr. Zisook, how do you find some clinician who offers prolonged grief disorder therapy?
Oh, it's difficult. So how do you find clinicians who offer this form of therapy? First of all, it's trainable. I learned how to do it. So I'm a clinician who does this. And if I can learn it, anyone can. Because I was a doubter in any kind of this kind of therapy. And we teach it to our residents. So we've had an elective for residents at UCSD, and 2 or 3 take it every year, and they're able to. Now, in the AFSP website, no, not the AFSP website, Kathy Shear's website. So if you Google prolonged grief disorder, you'll get to the Columbia website, which is Kathy Shear's, and she has a list of clinicians who are trained in this therapy in every city, and there are several in the LA area and just a couple in San Diego. That would be one way of finding it. In the absence of that, all the principles we heard in the last hour of listening, care, compassion, non-judgmentalism, etc., are very helpful. And in our study, although the prolonged grief disorder did way better than the group that didn't get it, the group that didn't get it still did pretty well because they were being treated compassionately and people were listening to them, and we were kind of managing their other symptoms. There aren't a lot who have been trained in this. The Kathy Shear website, the Columbia website will have that. I think the FSP one actually does as well. But get the training. It's available.
Are children survivors more or less prone for prolonged grief disorder?
What a great question, and we have no idea. I would guess that children who have suffered the loss of a parent or sibling probably have very high rates of prolonged grief disorder but has not been studied. And prolonged grief disorder is such a new disorder that there's very little data on it in terms of that kind of question. But an educated guess is that depending on the loss and depending on the support system that they have after the loss, they're probably at high risk for prolonged. All of the studies on prolonged grief disorder and treatment have been with adults.
I don't think I started. I think there was a lot.
Yeah. So as a 10-year-old losing a brother and not even thinking about it, totally common, and often infused with guilt feelings about the fact that you're not feeling it and you're not grieving, and then it'll come back later. in another time.
Is grief disorder individual treatment? And do you
Yeah.
know of any family or conjoined treatment for this work? Because
Yeah.
a lot of the data we see even from the suicide statistics demonstrate how important having supportive people in your network are, but because so many treatment modalities are very individual.
Yeah.
They say, "Oh, yeah, how do people don't incorporate?"
Yeah. So the question is, are these treatments individual or group? The three large controlled studies were all individualized treatments. There have been some smaller studies with groups that promise effectiveness, and sometimes in the groups they'll have primarily group therapy, but then some individualized sessions as well to do some of those exposure type therapy sessions with them individually. And those look like they're very effective. And there are other therapies besides this prolonged grief therapy that have been studied that tend to look like they're useful. There, some cognitive behavioral therapy type treatments. The largest studies with the most evidence are the ones I mentioned, but there are other studies with evolving evidence as well. The one common thread seems to be the exposure part. I mentioned this, the imagining the death of the person. It's kind of an exposure therapy technique. It's not prolonged exposure, but it's exposure. And it seems that most of the effective treatments have some exposure therapy as part of it to help the person face the loss. What we find is people with prolonged grief disorder have spent years doing their best to not grieve, to not face the loss, to avoid reminders. And the kind of the sine qua non is to help them grieve, help them face the pain, difficult as it is, in order to then be able to deal with the pain. Yes?
Yeah, so I was wondering for culture or religion that delays the grieving or like recommends like, oh, 6 months to a year, you should grieve. Does the timer start after the end of that, or the moment is like, oh, so and so passed away, timer starts down?
Well, if you look at the ICD-11 or the DSM, the timer is the death. But it's all very arbitrary. And I think one of the things they do say, the diagnosis shouldn't be made if the grief is within the context of one's spiritual or religious feeling. So that has to be entered into it as well. And the kind of 1 year thing, if I lost a parent to suicide, I don't want to be labeled with a disorder at 12 months or 13 months. It's all very arbitrary, and it depends on so many other factors. And diagnosis shouldn't be a checklist. It should be clinical consideration with lots of factors entered in. But if you look at the DSM or the ICD as the Bible of diagnosis, the clock starts at the death.
Thank you, Dr. Zisook.
Thank you.
That's